the KRAS G12C mutation and KRAS mutations in general have been known about for over 40 years as oncogenic drivers involved in the cancerous pathway, but they had been previously considered untargetable. More recently, it was shown that you could potentially irreversibly bind to the GDP portion of the molecule, the KRAS molecule, and inhibit enzyme production. And this was actually the very first study that randomized patients to a KRAS G12C inhibitor versus the standard of care docetaxel in patients who had previously received a platinol chemotherapy and an IO therapy, setting the stage now for the approval of Sotorasib in over 50 countries. The primary endpoint of the study itself was improvement in progression-free survival, and it met its primary endpoint doing so. Other secondary endpoints also supported that finding, including duration of response, time to treatment response. It did not, however, meet the overall survival, but the study was not powered to do so. So that's still an unanswered question that's been done. And as I said, the most recent presentation focused on patient-reported outcomes while achieving these different positive efficacy endpoints. It did not do so at the expense of the patient. In other words, the toxicities favored Sotorasib, and patient-reported outcomes, which are different than our measures of toxicity, also favored Sotorasib. Well, I think they're already impacting the treatment of non-small cell lung cancer. We know that KRAS mutations are seen in perhaps as much as 24 to 28% of the patients, of whom half of those have specifically the G12C mutation. So in other words, about 13 or 14% of all non-small cell lung cancer patients harbor this actionable mutation. Again, you won't know that if you don't do next generation test sequencing on these patients. So I'm going to be an advocate for comprehensive genomic testing in all patients with advanced non-small cell lung cancer. Once patients have failed the standard of care frontline therapy, which if they don't have a targetable mutation such as ALK, ROS, EGFR, and are treated instead with a usually a platinol doublet, often with an IO therapy. When they fail that treatment, as the majority of them will, this is a very viable treatment option in the second line. And for patients who harbor the G12C, I personally think that the results favor using Sotorasib as opposed to Taxotere in that clinical setting. This follows up on the presentation of the patient-reported outcomes, and I think that this is something that's very important. Historically, we have looked at toxicity through the lens of the investigators. I will look at the common toxicity criteria. I will grade their diarrhea. I will grade their fatigue. I may grade their rash or their laboratory findings. But that doesn't necessarily mean I'm measuring the impact of those toxicities on the patient and their quality of life. The use of patient-reported outcomes allows us to look at the results of the trial through the patient lens. How did these side effects impact their quality of life? And I think that we're seeing an increased use of patient-reported outcomes both in clinical trials and even the clinical setting. And I think that's a very good thing for our clinical trials and highly supportive of that endeavor.